My name is Dr. Pippa Corrie, and I am a consultant medical oncologist based at Addenbrooke in Cambridge, and I've been asked to talk to you a little bit about cancer immunotherapy. The history of immunotherapy goes back well over 100 years. It started in 1891 when a gentleman called William Coley noticed that some cancer patients had spontaneous remissions after developing a bacterial skin condition called erysipelas. He tried injecting bacteria into patients' cancers, and sometimes the cancer responded by shrinking. But Coley's toxins didn't catch on because doctors were worried about bacteria infecting cancer patients, and instead they focused on pursuing surgery and radiotherapy as treatment for cancer. By the middle of the 20th century, scientists began to discover how our immune system works. They identified immune cells or lymphocytes which act as sentinels to identify and destroy tumour cells. In the mid-1970s, a natural chemical or cytokine called interleukin-2 was identified, and this was used by scientists to grow immune T cells for the first time. IL-2 was subsequently tested in patients with metastatic cancer, and in the 1990s, IL-2 was approved as an anti-cancer treatment in the USA for patients with advanced kidney cancer and metastatic melanoma. A major advance in immunotherapy occurred towards the end of the 20th century with the invention of monoclonal antibodies. Monoclonal antibodies are a type of protein made in the laboratory that can bind to substances in the body, including cancer cells. Rituximab was the first monoclonal antibody to be made available as treatment for non-Hodgkin's lymphoma. In the last 10 years, a series of monoclonal antibodies called immune checkpoint inhibitors have been developed, and these form the basis of modern immunotherapy given to patients in the clinic today. Immune checkpoint inhibitors were invented by a scientist called Jim Allison, and he won a Nobel Prize in 2018 for this work. Jim had a long-standing interest in understanding how the immune system works. The T cell is the main immune cell responsible for killing cancer cells. And Jim was one of the first people to identify how T cells interact with tumour cells by the binding of cell surface molecules called antigens and receptors, a bit like a lock and key. He realised that interfering with these antigen receptor complexes could be a novel strategy for cancer immunotherapy, and he was proved right. The first immune checkpoint inhibitor which showed a benefit to patients was a drug called ipilimumab. Ipilimumab is a monoclonal antibody that blocks the CTLA-4 receptor. CTLA-4 normally works to keep T cells in a resting state. Blocking CTLA-4 activates T cells and in effect takes the brakes off the immune system. Ipilimumab was first shown to be an effective treatment for patients with metastatic melanoma in 2011. Now, although only about 20% of those melanoma patients got a good response to treatment, those who responded have remained in long-term remission, some being alive more than 10 years after treatment. Another important immunotherapy target is the programmed death 1 receptor, also known as PD-1. This receptor is found on both T cells and tumour cells, and blocking this receptor with antibodies such as pembrolizumab or nivolumab has been shown to generate better survival rates for metastatic melanoma patients compared with ipilimumab. Furthermore, combining anti-CTLA-4 and anti-PD-1 antibodies with regimens like ipilimumab plus nivolumab can generate even higher response rates than when using these drugs on their own. Now, immune checkpoint inhibitors have been tested and shown to be beneficial to patients with a wide spectrum of cancers, including lung cancer, renal cancer, bladder cancer, head and neck cancer, gastric cancer, and many more. The development of immune checkpoint inhibitors has not been entirely plain sailing. There are some important considerations I would like to share with you. Firstly, these antibodies generate some complex side effects, so I'm going to talk a bit about management of immune-related adverse events and patient safety. Secondly, in general, it's fair to say that the minority of people treated with immunotherapy will benefit from it. So we need to try to get a handle on who benefits in order to avoid unnecessary harm, and also being mindful that modern immunotherapy drugs are high cost. And finally, what strategies do we have so that more people can benefit from immunotherapy? Immune-related adverse events may be mild, but sometimes they can be life-threatening and/or life-changing. Their severity may depend on which treatment is being used. And there is certainly more toxicity with combination regimens such as ipilimumab and nivolumab. Most toxicities can be managed relatively easily, often by stopping treatment and using steroids and other similar drugs to try to dampen down the immune response. Some may not be reversible though. In particular, if your hormone system is affected, you may require permanent hormone replacement. Your doctor will always explain to you the potential benefits as well as risks of any treatment options before you start, and you will have emergency contact details to access help anytime if needed once you've started treatment. Most hospitals have a multidisciplinary team available to help with managing immune-related toxicities, and we rely on both national and international guidance to help with diagnosis and treatment of these side effects. The second problem I want to discuss is that not everyone responds to immunotherapy. A lot of ongoing research aims to identify ways of predicting for treatment response, resistance, and toxicity. Some of the ways of predicting response include your individual tumour characteristics, also your personal characteristics, and particularly those which influence your own immune system. For example, there's a lot of interest at the moment about how the bacteria in your body influence immunity and how they may also influence your response to immunotherapy. Interestingly, there is some suggestion that those patients who get severe immune-related side effects may also go on to respond well. Although it isn't quite so simple as that, and some people who don't experience toxicity can still benefit. Finally, what strategies are there for increasing the chance of benefiting from immunotherapy? First, we can give treatment sooner in the evolution of cancer. Much of immunotherapy has been developed in people with advanced disease. However, we now know that giving immune checkpoint inhibitors to patients who've undergone surgery to remove locoregional spread of melanoma over the course of a year after their surgery can pretty much halve their chance of recurrence. This kind of adjuvant therapy approach is now being tested for other cancers too. We can also combine immunotherapy with other anti-cancer drugs, both conventional chemotherapy, but also newer drugs being developed that target cells in the body and the immune system. Also, there are now cellular therapy approaches in which the T cells are extracted from an individual or their cancer, grown up in a laboratory, perhaps modified, and then returned